Good afternoon. I don't know how many of you are out there, but I'm in Spain, and the rest of the participants the professors are at Pasteur in Paris. I'd just first like to introduce the Pasteur team who's involved in putting this MOOC and the webinar together. First, the general directors of the Pasteur Education are Monica Sala and Thierry Lang, who've been very supportive of the entire MOOC. The responsable for this MOOC is Clementine Schill. The community managers, as you know, are Fadel Saiz and Ilse Lou. Those are the people with whom you've had contact. And for this webinar, we're dependent on the technical and informatics skills of Emerson Leonardo Alvarez Quinche and Odile Cismero. And the profs are Brigitte Jiquel, Nicolas Vizires, Roland Broche, Ludovic Tailleux, and myself. So I think, should we go to the questions that were that Fadel sent around? So I think the first one is for me. What's the use of the IGRA test, which is the interferon gamma reaction test, for TB diagnosis in the world? Recommendation, price, the sensitivity and specificity in different geographic regions, low and high countries. Well, I looked up a little bit about this on the WHO, which gave out an expert opinion in 2018. And the guidelines committee compared the TST, or the Mantoux test, the intradermal test, with the IGRA, and said that there were no strong evidence that one test should be preferred over the other for predicting progression of active TB disease, and that the intradermal test, or the TST, may require significantly fewer resources than IGRA and be more familiar to practitioners. So they strongly recommend the two as equivalent options, but there are advantages and disadvantages. One of the big disadvantages is that the IGRA tests require sophisticated laboratory infrastructure, and the costs are very much greater than the intradermal test. So they recommend that for lower middle income and low resource countries, they do not recommend the interferon gamma tests. They say that they should continue with the intradermal tests. However, you have to say that neither test can detect tuberculosis. They only detect infection. So they can't be used to determine whether a patient has tuberculosis. There are also false negatives, people who have tuberculosis or are infected and don't have a positive test. So neither test is perfect. They're sort of equivalent, but it's just that the interferon gamma is much more expensive. Now, the question comes that say the interferon gamma is more specific because it will not pick up previous vaccination with BCG. However, the WHO committee says that for people who are vaccinated at birth, which is for most high TB burden countries, the effect of the BCG on the tuberculosis test, either the TECT or TST or the interferon gamma test, is variable, and that it should not necessarily mean that you have to use interferon gamma test if the people were vaccinated at birth. There's another test, it's called the CTB, that's been developed in Denmark. It's an intradermal test. You inject it, but it only has the same antigens that are used for the interferon gamma test. So it shouldn't pick up anyone who's had BCG. But the tests, when they did studies of that, they were pretty much the same as just the basic PPD or TST test. So they have a little more specificity, but for low income and middle income countries, the PPD, if you can get it, there's been problems with getting enough PPD. The PPD is what should be used. However, people who are living with AIDS or child household contacts of children who are less than 5, especially in countries with a high incidence, they can have a negative PPD or interferon gamma test, and maybe they should still be treated. I think in France, any child less than 5 who's in a house with an active TB patient should be given prophylactic treatment with something, isoniazid or isoniazid rifampin, depending on the country. Okay, what's the next question? Would an application or interactive program for new TB cases or TB contact as well as follow-up be useful? Is this kind of monitoring system in low to moderate income countries complicated, or could ethical, privacy, and logistical issues arise? How can travelers protect themselves against TB? Okay, well, let's first take the TB monitoring system. Over the past few years, several systems called VOD, instead of direct observed therapy, where the patient comes to the clinic every day and somebody watches them swallow the medicine, this can be done through a cell phone, where you can take a video of the patient swallowing their medicine, and then the video is uploaded to a server, and then the doctor can look at it at their convenience. We did a system like that in China. It's only available in Mandarin. It's not available in English or any other language. But the results seem to be good. And especially during something like the pandemic, that becomes very valuable. But the problem seems to be with the pandemic, which we can talk about later, is not in follow-up, not in people getting their medicine, but in the diagnosis. And for that, the monitoring system, or VOD, video observed therapy, video observed drug therapy, would not make a difference. However, I think that if it's well done, it can make a difference. And the studies that have come out now of systems around the world seem to show that it can be beneficial. How can travelers protect themselves against TB? That's difficult, because there's recent studies that suggest that it was thought that tuberculosis is passed in big droplets. Now, there's some recent studies suggest that it can be aerosolized and that it can stay in the air for a long time. I mean, one thing with the pandemic is maybe there's less TB transmission because everyone is wearing masks. So can you wear a mask if you go to a high TB incidence country? Well, you can. I'm not sure how convenient that will be, but I would say to stay out of closed environments where there are a lot of people and people coughing, and buses, or stay away from people who are coughing. And what's the most common cause of TB drug resistance in low-income countries? The most common cause of cases of drug resistance in over 70% of all the cases of multi-drug resistance is from transmission. There is some TB, maybe there'll be poor TB therapy because of the pandemic, and then so there may be some more primary drug resistance developing, but most of the resistance, over 70% or 80% in some countries, is caused by the transmission of strains that are already resistant. In other words, this is primary resistance, not secondary resistance, where you develop it. So primary resistance, the transmission of MDR strains or drug-resistant strains, is the most common cause of drug resistance in, I think, all the countries in the world right now. Okay, so let's go on.
Howard, I have only one comment. Just compare it to drug-sensitive mycobacteria. When the drug-resistant mycobacteria stop being transmitted after starting treatment? Because in reports after 3 weeks of daily treatment, it could be not anymore contagious as TB in drug-sensitive mycobacteria. But is there any percentage or any information about when the patient in treatment become safe?
Well, I think that usually it's thought that after about 2 weeks of therapy, the patient is not going to be very infectious. Okay. However, there was a recent study a few months ago that showed that the aerosols from patients with TB can persist longer than 2 weeks, and they still have bacilli in their sputum. They're much less, but there can still be live transmissible bacilli in the sputum much later, although that is not the normal, what people normally think now is after about 2 weeks of therapy, there's much less TB, which is probably right because the initial drugs, especially attenuated, work and reduce the number of bugs very rapidly, but some might persist for longer than 2 weeks. Any other comments from anyone else? So if not,
thank you very much, Howard.
Okay, if not, let's go to Nicolas Viziris, who can introduce himself. He is responsible for treatment of all the multi-drug resistant TB in France. And the questions for Nicolas are, what are the advances in clinical and molecular tools used in drug sensitivity testing, MDR and XDR-TB? Are there new treatments for MDR, XDR-TB? What about their efficacy, side effects, availability in low-income countries? What do you think about shortening the TB treatment in children with minimal disease? That are new WHO recommendations. And what are the factors, physiological, case-specific, country, health program, politics, that could be considered for adopting a treatment regimen against drug-resistant mycobacteria? That's a lot. Nicolas?
Yes, thank you, Howard. So hello, everybody. My name is Nicolas Viziris. I'm a professor of bacteriology at Sorbonne University in Paris, and chief of the bacteriology lab of the Saint-Antoine Hospital, and involved in the National Reference Center of Mycobacteria. And as Howard said, I'm especially involved in treatment advice for difficult to treat TB cases. So the first question, what are the advances in clinical and molecular tools used for drug susceptibility testing, MDR and XDR-TB? So there are a lot of advances. I would say that of course, whole genome sequencing is progressing. It is not, I mean, the traditional whole genome sequencing is not routine use, I think, at least in most countries, mainly because it's difficult to have results rapidly. I mean, enough to take treatment decisions, but it is progressing. What is already in use, I think, in many places, and it's the case at least in France, is targeted new genome sequencing, like, for example, the duplex, which provides sequencing results for about 13 antibiotics, anti-tuberculosis drugs, and with also interpretation of the mutations you detect. And so you can do that on culture positive specimens, and you can do that also on samples if they have enough bacilli. So that means there must be already quite a lot of bacilli at the microscopic examination. And so that's really a very, very useful tool for deciding for treatment. So that's what we have. What already exists, if I would say, on top of just testing for rifampin of whatever RPOB testing, and which should be maybe first implemented, is probably just do isoniazid testing, because it's quite clear now for everybody that when the isoniazid resistant strains are the ones from which you will select multi-drug resistance, and of course that means that you must identify those cases in order to give the right treatment and avoid the selection of MDR. So there are a number of commercial tests that do exist and that do propose the combination of rifampin and isoniazid molecular testing, and I really encourage the use of these tests. And to finish with this question, it's something we don't really have for the moment, except for with the duplex, and even the duplex is not complete. But you know, or you don't know that the definition of extensively drug-resistant tuberculosis has changed since January the 1st. It's now MDR infection plus fluoroquinolone resistance, plus either bedaquiline and or linezolid resistance, and which makes sense because those are the most effective drugs for MDR treatment. But that means, of course, that we need to be able to diagnose resistance to both bedaquiline and linezolid. And so except a part of the duplex, I'm not aware of any test allowing the molecular test for diagnosing the resistance to those drugs. And phenotypically, at least for bedaquiline, and genotypically also, it's quite a challenge. So probably there need to be some research to have tools for, I would say, everyday life for those two drugs. So next questions. Are there new treatment regimens for MDR and XDR-TB? What about their efficacy, side effects, availabilities in low-income countries? So there are quite a lot of new regimens, and I mean, the last one has been presented yesterday. So there's been the NIX-TB regimen. The NIX-TB regimen is the combination of bedaquiline, linezolid, and pretomanid. And this combination in a publication in the New England, I think it was last year, it was a non-comparative trial, has shown something like around 90% efficacy in XDR or MDR patients that have failed an MDR regimen, so which is really an excellent result for an entirely oral regimen. Yesterday at the Union Congress, Médecins Sans Frontières, so Doctors Without Borders, has presented the result of the a trial in which they evaluated for MDR-TB, and it's a comparative trial this time, more or less the same regimen, so bedaquiline, pretomanid, and linezolid, but with on top of that moxifloxacin, so 4-drug regimen, and they show equivalent efficacy. So it was just a presentation, so we need to have more data on the toxicity and on the selection of patients, but that is confirmatory of the NIX-TB, so which is good news, and both are of course entirely oral. So in both of those regimens there is linezolid, and there is clearly a toxicity issue with linezolid because there is optic or peripheral neuropathy that occurs after weeks of treatment. And so probably the future will be to try to shorten the duration of linezolid. A trial called ZENIX, which was after NIX-TB, has tried to shorten this duration. There have been encouraging results that have been presented, so we need to see the publications now. So I don't have any information on the availability in low-income countries, and clearly those regimens which are really encouraging because they are entirely oral and active, they've been developed by Doctors Without Borders, so it's obviously for low-income countries. So next question, what do you think about shortening TB treatment in children with minimal disease in the new WHO recommendations? So I'm not a pediatrician, I do not take care of children myself, but I would say generally that tailoring the duration of treatment in relation with the extent of the disease really makes sense. We've been used to give, let's say even for drug susceptible TB, we've been used to give the same treatment to all the pulmonary TB cases, whatever the extension of the disease. And that is a little bit weird because I mean, I was trained as a pulmonologist, and if you think about another disease, which is the lung cancer, there is a staging, and depending on the extension of the disease, the treatment will change completely, and the duration, and the drugs, and the surgery. I mean, everything will change. And here, for pulmonary TB, I mean, we say, okay, we treat everybody the same way. If you have only a small granuloma, or if you have extensive disease, it will be almost the same treatment. So of course, this does not really make sense, and there are a lot of new data showing that probably we can treat with shorter regimens, possibly bacillary disease, and we probably require to treat with a longer regimen, longer than 6 months, extensive disease. So with the limit that I'm not a pediatrician, I do not treat children by myself. Children do have possibacillary disease. Most of the time, it's even difficult to make the bacterial diagnosis. So it makes really sense to shorten the duration of treatment in this population. Last question: what are the factors, physiological, case-specific, country health program politics, that could be considered for adopting a treatment regimen against drug-resistant mycobacteria? So I have absolutely no experience in setting up a TB programs. So I'm really, an everyday doctor, but not I do not set up TB programs. What I can tell you is what we do in France, the French experience, at least my experience. We did set up, something like 20 years ago, a TB consilium, and we try to do individualized regimens. So of course, we take decisions based on WHO recommendations and on updated science, but we really try to do those individualized regimens. It's really easier now that we have easily access to a video conference like the one we're doing today. So we do that every other week. The practitioner that is in charge of the TB, difficult to treat TB patients, MDR or whatever, he connects to this conference. He has to fulfill a file before describing the case, and there are TB experts. You have the microbiology expertise also, and with that we try to do individualized regimen, taking into account, of course, the toxicity of the regimen, or something which has, maybe the patient has a renal insufficiency or whatever, to have to do a tailored regimen. So that's what we do in France, and the literature I've seen really supports individualized regimens, which show that a better efficacy than doing a program for everybody. Of course, it is not possible everywhere. I'm really aware of that, but that's the experience I have. And I would say that at least for the most resistant to treat cases, that would be really interesting, or at least the ones that do experience toxicity and for which you need to do some adaptations. So that's for my answers for the questions that I had before. So I don't know if there are others.
Okay, thank you very much, Nicolas. If any of the participants who are listening have questions, please write them on the chat site. I think that was a very clear explanation for the answers. Brigitte, Jiquel, the questions for you are, why is the development of new anti-TB vaccines and drugs so slow? And what standards must be considered before entering human clinical trials, including safety, immunogenicity, and protection in different in vitro and animal models? And then, what are the most adapted and promising anti-TB vaccine strategies? Brigitte?
Thank you very much for inviting me. I will concentrate on vaccine, not much on the drugs. And for vaccine, for instance, we should recognize that it has been easy to have vaccines against bacteria producing toxins, because toxins are made massively, are secreted, and are going to target the immune systems at the different levels. And for instance, it has been easy to have a vaccine against tetanus and against other important diseases. But for other bacterial diseases, always it has been very difficult to have a vaccine. For instance, including vaccines against several meningitis and vaccine against cholera, it is still difficult. And if we consider tuberculosis, the bacilli is not producing toxins. So we are not expecting to have a good vaccine by using a toxin. There is no one. And this is why it is so difficult. But there are many proteins and antigens that are secreted, and maybe we could isolate some good antigens. But I think we forget some papers published during the 90s by the lab of Jerry Elner, with Henry Boom, with Bill Jacobs, and showing, for instance, that each vaccinees are responding differently at different antigens produced by cosmids. And I think we are forgetting this paper, which is showing how difficult it will be to have a vaccine because the different vaccines are going to respond differently. However, we had the BCG constructed by serendipity. I am not going to make a training course right now, but BCG is not protecting more than 50% the young children. And since this vaccination, we have tried a lot, many research programs, including many laboratories, and nowadays we have no vaccines protecting better than BCG. And this is really a problem. But I think we have some hope. And for instance, we have different kind of vaccine candidates. We have, for instance, new attenuated vaccinal strains, TB attenuated by transpositions. This is the project of Carlos that started in my lab many years ago. And now this project taken by Saragossa and by BioFabry is under phase 2 trials, and it looks quite promising. And it is, we are targeting responses to all antigens that could be seen by the vaccines and try to get protection. Also, a lot of work has been done, and we think, I would have some tendency to think that, for instance, if you have a good response against toxins for bacterial diseases with toxins, probably these toxins are disseminated through blood or other liquids in the body, and probably they are going to target stem cells at the level of the bone marrow and maybe induce strain immunity and induce several components of the innate immunity that are useful for adapted immunity. And this is what we need. And for instance, we have, for now, new ways to look at antigens. Probably it will be possible to look at, with system biology in immunology, we could target some antigens that are recognized by many people, not only recognized, but by people that are going to produce trained immunity, innate immunity, and required adapted immunity. We have many ways now, and in artificial intelligence to look for antigens that are really the one that we should use for vaccination. And for instance, we will have to wait a bit more. But I wanted to insist on the fact that we are not surprised with tuberculosis, because it is the case for many other bacterial diseases. And for instance, we have also many other studies recently published. A paper, for instance, by Nacho Aguilo in the lab of Carlos Martin, and with the discovery that mucosal immunization by respiratory route is very efficient in animal models. Also, I would like to mention the previous papers by Joan Flynn and others showing that vaccination by IV, which doesn't look very practical to perform, is able to induce good immunity in the macaques. But I don't think that we are going to use IV route for immunization in large populations. But this is to confirm that probably trained immunity and targeting of stem cells in the bone marrow is very important. And this is one of the things we miss for an efficient vaccination. So this is for vaccines. For drugs, I think I would be very short with drugs, because personally I believe that if we put more money for discovering drugs, we will get new drugs. And we have discovered new drugs, bedaquiline, for instance, and others under development. And I think we put enormous amount of money to look for drugs against AIDS. And we did that by modeling, and in vaccine research for drugs, we did the search of new drugs by classical testing with high-throughput screening and very classical screening, not things innovative with a new discovery on 3D structures. And I think we miss money and we miss people to use that money properly, of course. And now I think the last questions was the different steps before putting on the market and at human availability drugs or vaccines. Indeed, first of all, the products should be safe. Safe by testing with animals. Second, should be efficient by testing with animals. And then non-toxic and efficient by testing with humans. And the rule is to undertake the first trial, the first human trial, in the very country where the product has been discovered or manufactured, or Europe, for instance, Spain or France or Italy, if we are in Europe, but not in another country. And then for the phase 2 and 3, we should consider countries in need of the product and also safety and so forth. I don't know if I have answered all the questions, and I think you can add additional questions for these topics. Thank you.
No, thank you. It's clear. In fact, you even covered the promising anti-TB vaccination strategy, as you mentioned, aerosol immunization. Yes, that's quite clear. So, because I wondered also, we read a lot about different prime boost, repeated immunization could be conferred more protection as prophylactic or even as post-exposure vaccination. A different step of because it's really tricky latent TB to prevent not only the infection, which is really goal, the objective to prevent, if we can, the infection in first place, but also the reactivation of after 5 or 10 years. So, which maybe we need a different rappel or boost. Could be. No, it's really clear. Thank you very much, Brigitte.
Okay, and again, if there are any questions, please put them on the chat. And now we're going to go on to Roland Broche. And Roland, would you like to tell us more about the advantages of new generations of live attenuated vaccine candidates, such as Brigitte was mentioning, that are currently in development, and when might they be available? And then, as a sidelight, should it be considered that specific vaccine strains might be more applicable in some geographic areas, according to the dominant endemic TB lineage, as well as the human genetic background? And also, what can be learned from the evolution of TB-causing mycobacteria research for the design and development of new TB vaccines and drugs? Well, good luck with that one.
Hello, thank you, Howard. Hello, I'm Roland Broche. I'm working at the Pasteur Institute, leading a group we started off with working quite a lot on genomics of the tubercle bacilli, but also tried to develop recombinant BCG vaccines. So as regards the first question, I think one of the main purposes of this new live attenuated vaccines compared to BCG is that they have additional antigens that were lost in BCG due to the attenuation process. So one key region in this is the region covering the genes for the EZ6 or type 7 secretion system. And when you look, for instance, to the MTB VAX strain that Brigitte mentioned already, which was developed in her lab together with Carlos Martin and is now in production with BioFabric. I think the the MTB-VAC strain, which is an M. tuberculosis strain, which was attenuated, but still contains the region of the type 7 secretion system, ESX1, has about 500 more epitopes compared to the BCG strain. We also should remember that BCG is derived from an M. bovis strain, so maybe there is also some difference here, even though M. bovis is 99.99% identical at the genome level to Mycobacterium tuberculosis, but it gives a different disease and is transmitted differently. But there are a few mutations which cause these differences. So I think, yeah, this is one of the main reasons. We tried in our lab to a similar or a different strategy, but with a similar outcome, because we have tried to put this ESX1 secretion system back into BCG, and we also see an increased immune signaling with this kind of with this addition. So I think this would be one main answer, that there is a different signaling and a higher load of epitopes which can be targeted. And as we know from vaccination, BCG is one of the still best vaccines against tuberculosis. There have many protein vaccines, for instance, been tried in preclinical systems, but also in human trials. And apparently you need a lot of different epitopes and antigens to stimulate the correct immune response. But we also know in the same time that BCG, of course, doesn't protect against pulmonary TB to a very high degree, and in the adult population and in the adolescent population. So I hope this was some answer to the first question. The side questions: should we consider the use of specific vaccine strains in some geographic areas according to the dominant endemic MTB lineages as well as the human genetic backgrounds? I would say I think this question is related maybe to some observations that, for instance, in areas where the MTB lineage, lineage 2, also called Beijing lineage, is prevalent, it was reported that BCG doesn't protect as well as against other strain lineages. And this was also observed in preclinical model, in the mouse model. One way to overcome this problem is also maybe to add additional antigens or the ESX1 secretion system, as this was shown that with increasing the immunogenicity, you can also protect against Beijing lineage strains. And this was also the strategy, for instance, of the strain that was developed, the recombinant BCG strain that was developed in Stefan Kaufmann's lab, that the purpose is to have a stronger innate immune response and a better CD8 response against this vaccine, which is apparently important against this Beijing lineage or lineage 2 and tuberculosis strains. There was also recent work by the group of Carlos Martin, where different strain backgrounds were used for making the same mutations as the MTB-VAC attenuated vaccine strain. And they used lineage 2, lineage 3, and lineage 4 strains. And the conclusion of the paper, which was published in eBiomedicine not too long time ago, was that apparently the lineage 4 background for MTB-VAC was quite appropriate, because it gave this kind of balance between a very acceptable level of low virulence and the protection level was appropriate against all the different lineages of MTB strains that were tested. for the last question, what can be learned from the evolution of TB causing mycobacteria? Researches for the design and development of new TB vaccines and drugs. I think this question relates to the origin of the M. tuberculosis strains, which we believe is linked to the M. caneti strains, the so-called M. caneti strains, which is a specific cluster of strains that are found in East Africa, around the Horn of Africa. And when you compare these strains to, which can also cause tuberculosis in some rare cases, there are only about 100 strains isolated for the moment compared to the many MTB strains that are isolated. I think these strains are less virulent in the murine models, for instance, and they also cause much fewer cases. This is epidemiologically very clear. And we have found that, for instance, these strains are much less persistent in the mouse model. And I think from comparing Mycobacterium caneti strains to M. tuberculosis strains, we can learn the reasons for persistence. For instance, this was we had a common recent work with the team of Christophe Guillot in Toulouse at the IBBS, and due to experimental evolution experiments, it was shown that, for instance, M. caneti strains, when you passage them in mice, you can increase their persistence. And this increase of persistence was accompanied by some specific mutations in some genes. So we have now some evidence that certain genes which are involved in the response against different stresses are important, that Mycobacterium tuberculosis can persist. This would be, for instance, one item I would mention here. For TB vaccines, I think this is also a question of finding new antigens, but as the tuberculosis-causing bacteria are very closely related to each other, I think they all contain more or less the same antigens, except for some which have lost some, like I said, for BCG, which has lost quite a lot of antigens due to the loss of the RD1 region or the ESX1 system. So, thank you.
Okay, thanks very much, Roland. We're going to move now to change gears a little bit, and Ludovic Tailleux, he's going to tell us about instead of drug therapy, instead of how maybe is it possible to improve the immunity of the patient so that they can fight off the disease better, fight off the tuberculosis better. And then maybe there are specific subpopulations of innate immune cells that are important in combating the tuberculosis. I mean, a problem is that we talk about the immunity in vaccines is it's not really clear what cells or what's the basis of immunity against tuberculosis. So that makes it difficult when you don't know what you're trying to stimulate. But if Ludovic can talk about that, inhibition of receptors, signaling and metabolic changes, et cetera, and the potential synergistic of host-based therapy with classic anti-TB drugs.
Okay, thank you, Owen. Thank you, Farrell, to invite me to talk about this important topic. So I'm Ludovic Tailleux. I worked during many years in Brigitte Gicquel's lab, and now I'm working in Roland's lab at the Institut Pasteur in Paris. So as you know, the 4-drug regimen has been introduced about 50 or 40 years ago, and since then, despite important investment by scientists or by funding agencies, there are only very few drugs, new TB drugs, that were approved and released recently. So in addition to the development of classical anti-TB drugs targeting key factors in MTB physiology, host-directed therapy, or HDT, have emerged as a promising strategy. By either targeting host antimicrobacterial pathways that are blocked by MTB inside the cells to promote its survival or its growth, or by potentiating antimicrobial host immune defense mechanism. So as you know, MTB manipulates host cell signaling pathway to subvert innate and adaptive immunity. So in theory, it might be possible to reprogram the host immune system to better control or even kill intracellular MTB. So some studies have been performed in vitro and in vivo and have identified some compounds that allow the macrophages, which are the main cell target of MTB, to better control the bacteria. So this molecule can promote the phagosome maturation. For example, the metformin, I will give you more detail about these drugs. This molecule can trigger autophagy. Another example would be the vitamin D. They can inhibit the lipid body formation, the statin, for example. They can induce antimicrobial peptide or to trigger macrophage activation. So several HDT have been developed to improve antimicrobial defense or to decrease inflammation in the lung, and some are in clinical trials. But you have to keep in mind that it's most likely that this new drug will be used in conjunction with classical antibiotics, and they will not replace the antibiotics. So I can give you two examples of HDT, the classical examples of HDT. We can talk about the vitamin D. So the vitamin D, at least in vitro, can induce the macrophage activation. So vitamin D will bind to its receptor and induce the transcription of the antimicrobial peptide catalysin D, which activate autophagy inside the cells. So there are many trials with adjunctive therapy with vitamin D that have been tested, but unfortunately there are no clear conclusions. In one trial, it suggests that vitamin D supplementation promotes radiographic improvement in TB patients and increased host immune activation, but only among patients with a previous vitamin D deficiency. The example is metformin. The metformin is a drug used in diabetes. It is an anti-hyperglycemic agent with some immunomodulatory effects. This drug promotes autophagy. It promotes phagosome-lysosome fusions, and it induced the mitochondrial ROS production, which promote the phagosome maturation, at least in vitro and in vivo in the mouse models. Importantly, this drug also enhanced the activity of classical TB drugs, so isoniazid and ethionamide in the mouse. And when you look in the data in the humans, several studies have demonstrated that metformin is beneficial for diabetic patients by reducing the risk of TB, and several trials are ongoing to evaluate the use of metformin with other TB drugs among patients with and without HIV. And more recently, we have shown in the lab that betaquilin, which is quite new antibiotics against TB, also promote autophagy inside the cells and has an effect on the host. I think I finished with the HDT.
Okay, thank you very much, Nicolas. There was one question from Malamba Lubilanji Eric. Basically, can the Expert MTB RIF test be used in zones of limited resources? Well, that's a very good question, because it was designed to be used in places with limited resources. It's very easy to use, doesn't require much work, much technical expertise. But the problem is that in places with low resources, if there's a lot of dust, the machine doesn't work very well. It tends to go bad very rapidly, and it's very hard to have it serviced. They were going to make a model called the Omni, which would be battery operated, wouldn't need electricity, which can be a problem in low resource countries to have a constant source of electricity. But the Omni has been promised now for about 4 years, and I still haven't seen it come out. However, the Expert recently came out with a new model that can detect isoniazid resistance and fluoroquinolone resistance and resistance to injectables. And recent studies show that does pretty well, and it's very accurate. But the problem is still that when you're really out in very rural areas, you need electricity and you need a clean space without a lot of dust. So it can be used in low resource countries, but it has to require some infrastructure for it to work well. Otherwise, it starts working and then very shortly the machine stops working or is not very good, not very accurate. And it's very, as you know, it's very hard to get technical repairs in rural settings. You have to pay, it's very expensive to bring somebody from the first world to fix it. I thought we should deal a little bit with the effect of COVID and on tuberculosis. There's a lot talked about that. There's a recent article that I saw that I thought was very good. I'll put this reference up. In that basically it says there's a lack of data at this point. Originally it was modeled and it was thought that there was about a 30% decrease in the number of tuberculosis patients registered during the pandemic, because people just weren't going to get diagnosed. And it thought that there might be an extra 1 million TB cases in 2021, and that a lot of you've seen a lot of people saying that the struggle against TB has been set back for several years. The progress that we've made against TB over the past 5-10 years, a lot of that has been destroyed, and we have to start over again because the healthcare infrastructure has been all dedicated to COVID. There's been less money for tuberculosis. In the pandemic, the doctors were all concentrated on COVID, and the patients in the pandemic wouldn't go to the hospital to be diagnosed. What this article says is that all those studies are from 2020, and 2021, there is not that much data. So for the participants, the people who are listening, it would be good for you to try to evaluate in your TB programs, if you're involved in TB programs, what has been the effect of COVID? Has there been a decrease in the number of patients? Other possibilities are tuberculosis, poverty increases tuberculosis, and there's been probably a big jump in poverty in a lot of countries, which will probably increase the amount of TB. What's the effect on transmission? People don't go out so much, so there's not such chance to transmit, but then the people are kept inside the house, so the people who have TB will transmit it more to the people who are in the home with them. That doesn't seem to be as much of a problem with treatment. The problem seems to be in diagnosing it. The people who are on treatment, that there were some problems, but that doesn't seem to be as much of a problem as simply the diagnosis. So I will open it up. Does anyone else have any comments? Does any of the students have any comments? Yes.
Howard,
Go ahead.
I can just mention something I also read in the reports about the impact of COVID-19, not only on the diagnosis or the number of reported cases, and which unfortunately is really huge, and it gave us back to annual mortality of maybe 2011 or something like this, which is quite huge, but also the impact on drug supply chains and the control programs, which is increased the risk of drug resistant. So I'm not sure if it's really accurate, but also the drug resistant MTB could be affected, but indirectly by also COVID, not only the general number of, unfortunately.
Yes, that's an important point.
Yeah, but we should consider that TB is a long-term threat and than any other infectious disease, and closely linked to poverty and other condition, which is unfortunately will still a great challenge for the next years. That's sure.
But I think that what this article stressed, and I'll put up the reference, is that
Thank you.
for the future, TB programs are going to ask for more funding, and they say they have lost their funding. But I think what they say is there's not enough data right now. So for people in TB programs in countries around the world, I think it's important for you to try to document the decrease in the diagnosis or the decrease in the outcomes or the decrease in the number of people on therapy. And with that data, you can better go to your funding agencies or the government to ask for more funds. But without that, there's not a lot of good data right now to justify more funds. More funds will be needed, but I advise you to try to collect the data in your programs and then use that to go to your government to try to increase your funding.
Yes. I also have only one maybe comment about the vaccination and COVID vaccination by BCG, in fact, and the COVID-19. There is two, I would like to highlight two main good paper, Escobar in PNAS last year and O'Neill in Nature Review Immunology. They shown that there is a correlation between BCG vaccination in childhood and decrease in susceptibility to respiratory infections and severe coronavirus disease manifestation, which suggests probably, as Brigitte mentioned before, due to the BCG-induced general long-term trend immunity, which is quite good and in this field and bring us the importance of BCG vaccination due to its non-specific and pleiotropic benefit. I will add the two paper in the MOOC if you want to read it. It's a really important data. Thank you.
So, are there any more comments? We're about finished with our hour. Are any more questions or comments? Yeah, I guess the other thing with the expert, just their questions about the expert, is that the price of the expert varies dramatically. In some countries, it costs $100. In some countries, it costs $10. So, but there's no control over it. You don't know why some countries have more, it costs more or less. But in one study, which is the country in Europe that has been having the most financial problems over the last, I don't know, 10 years? I would say Greece. Which is the country in which the expert costs the most in Europe? Greece. So there's not a lot of logic. I guess it's distributed by local private distributors, and they charge whatever they think they can get away with. So some countries it's free, some countries it's not. It's similar, but the duplex costs even more, and it probably you need something like, there are some other tests that do the same thing as expert. There is another test from India, and there's a melting curve from China, and I think the one from India, the TrueNat, I think that is not as subject to problems with dust as the expert, and it seems to work quite well. but the cost, I mean, most low resource countries can't afford $40 for every test for drug resistance. Maybe they can afford $10, but still, if you have to test 100,000 people at $10, that's a big expense. So yes, the funding it works, but there's a problem with funding, and there's a problem where you want to get the test out into the rural area where you could rapidly diagnose multi-drug resistant TB. There's not a perfect test at this point. Any other questions? If not, I think we've finished the hour. Thank you very much for all the participants, for answering all the questions. Thank you, Fidel, for the questions. And thank you for the staff of the Pasteur who has put this all together, especially Emerson Leonardo Alvarez Quinche and Odile Cismero, who did the informatics part. And if there are any questions of any of the participants, thank you for attending. If you have any questions, we'll send them to Fidel, and he will farm them out to someone else if he can't answer them.
Yes, of course. We will still collecting the question even after the session. We can ask it. We can respond directly on the forum, so it's okay. And I would like to say also for those who could not participate today with us in the live session, you will have the opportunity to see and watch the broadcast soon. It will be available on the MOOC after some adjustments, so it will be okay for everyone, available for everyone. And we'll still collecting your general question, as well as the technical one, and until the end of the MOOC. So it will be great. Thank you very much.
Thank you. I hope the MOOC has been useful, and I hope this webinar has been useful. Thanks very much to everybody.
Thank you. Bye-bye.
Thank you. Bye-bye.
Thank you.
Bye.